Yeah. Okay. So I'm a tissue viability nurse working for nurse specialist working for Coloplast, and I'm going to be running the webinar tonight on surgical wounds. So we'll get started. So the objectives of tonight's session, we're going to introduce you to the Coloplast 3-step approach, which is a step-by-step framework which, if you use it, you can effectively assess and prepare and treat surgical wounds. We're going to learn a simplified approach to wound healing, understand the impact of surgical wounds and surgical wound breakdown, gain an overview of the latest recommendations from the National Wound Care Strategy Programme and the Prevention, Identification and Management of Surgical Wound Dehiscence consensus document that was released. You won't leave tonight with the Coloplast 3-step approach pathway because the National Wound Care Strategy Programme have just updated their recommendations, but we will be in touch at a later date once we've updated our pathway in line with that document. So we do have you, we'll pop forward that on at a later date. So the burden of wounds in the UK, you might have seen this data before, but this is based on the Julian Guest work that was done a few years back, and they found that there was 3.8 million patients with a wound being managed annually by the NHS, which was an annual cost estimated to be 2.7 billion for healed wounds and 5.6 billion for the 30% of wounds that didn't heal. It's estimated that 59% of chronic wounds heal if they have no evidence of infection, compared with 45% if there's a definite or suspected infection. The presence of biofilm in a chronic wound is greater than 80%, and 46% of healthcare professionals believe that infection is a challenge when treating wounds. And I'm sure, as all of us being healthcare professionals, that's something that we'll probably agree with. So just an overview on surgical wounds. 52% of the cost of acute wounds is contributed to the care and management of surgical wounds. Caring for surgical wounds in a primary care setting accounts for 8.9 to 21.8 of the total wound care expenditure of the NHS. So it's actually quite a big proportion if you think about the majority of wounds in primary care are predominantly leg ulcers. So it is quite a huge amount of money that is being spent on surgical wounds. Most surgical wounds do heal without complication or delay, but some don't, which affects the clinical outcomes and the patient's quality of life. There can be, obviously, they've got an open wound, there's a lot of pain, exudate could be an issue, things like that. By raising awareness, improving identification, prevention and management, it'll help prevent negative impacts on patients' quality of life and associated healthcare costs, because we can treat things before they get bad and get massively infected. There is evidence to suggest there's a suboptimal approach to the care when complications occur. And due to the need of earlier discharge post-operatively, most complications occur in the community. So obviously there's a lot of enhanced recovery programmes around now for various operations. I mean, some areas, hip replacements are coming out and only going in for a day case, so they're moving patients post-operatively out of hospital a lot sooner. So the complications, if they do occur, are occurring in the community or primary care settings. Early intervention, as well as healthcare professional education, is key to preventing escalation and deterioration severity, allowing patients to have a more accurate and timelier treatment. The wounds can heal by either primary or secondary intention. Predominantly, you will see your surgical wounds healing by primary intention, and this is where the wounds close within hours of injury and where the wound edges can be brought together nicely without any tension. So you do see this in your uncomplicated acute wounds that generally heal by primary intention. They use this like sutures or clips or staples, things like that, to bring the edges together and make sure that they adhere together. They're not normally suitable for your long-term chronic wounds or those of a large cavity, which we'll come on to on the next slide. So this is secondary intention, which is what you want to do with your chronic wounds or your large cavities. And this is where the primary closure is not possible. So the wound should be left open to heal spontaneously through the process of contraction and reepithelialization. So you're wanting that wound to heal from the bottom up. So it's used in your hard to heal wounds, infected wounds, and those unsuitable for primary healing. It allows the body to naturally heal the wound from the base up, meaning new tissue and capillary formation. Wound healing can transition between the healing stages, and the inflammatory stage can be prolonged, which is especially if there's an infection or a biofilm. And complex wounds should be monitored closely by staff who are trained to do so. So this is the Coloplast 3-step approach. So the idea is that we're going to simplify wound healing. So step 1 is assess. So we've got a holistic and wound assessment is paramount for defining the treatment objectives, and you want to be utilising the triangle of wound assessment here, where you look at the wound bed, the wound edge and the peri-wound skin. You then move around onto step 2, which is prepare, and wound preparation is key to removing the barriers to healing, creating an optimum healing environment. And then step 3, you then utilise a simplified portfolio of dressings to manage the wound at any depth, at any stage of healing. So what we'll do is we'll go through surgical wounds and we'll break it down through each step of the 3-step approach. So we've got step 1, assess. So in our wound assessment, when we've got a surgical wound, we want to be identifying the cause of the skin breaking down. We need to know what the reason behind the surgery was, because that'll help us look at obviously if it'll affect the healing. So if they've had surgery for Crohn's disease, for example, there may be certain medications there that they might be on that might delay healing. We want to identify any associated risk factors as well. So is the patient had a C-section and are they obese, so they're more likely to have a dehiscence. We need to treat and correct the underlying cause if possible. We also need to identify appropriate management options. So if we go back to the slides where they were talking about primary and secondary intention, if we've got a large cavity, an appropriate management option wouldn't be to bring the wounds together and close them by primary intention. We want to be leaving the cavity open. We need to be looking at the wound related symptoms and control them in the assessment, that they'll be picked up in the assessment. We want to prevent any further wound or skin deterioration. We also want to identify the patient's expectations. What do they want out of this? Is there anything in their life that would mean that they need to have a certain type of treatment, certain type of dressing? And we also want to provide psychosocial support and promote patient independence through supported self-management wherever we can. As I've touched on already, we've got the triangle of wound assessment. So it's a holistic wound assessment framework to assess and manage all areas of the wound. So as I said, we've got the wound bed, the wound edge and the peri-wound skin. And the idea is it's to support optimal clinical decision making in all through three areas, which will get you the perfect kind of management dressings and things to kind of get on top of that. So we'll cover them in a second. So here, the wound bed assessment. So when we're looking at the wound bed, you want to be looking for your tissue type. So is the tissue type necrotic? Is it sloughy? Is it granulating? Or is it epithelializing? In this area, we always want to be looking at exudate levels as well. So is the volume, is there no exudate? Is it quite dry? Is it low, medium or high? What's the consistency as well? Is it thin and watery or is it quite thick? And also what's the colour? Is it clear, cloudy, purulent, pink and red? And all that can give you indications of things like infection, because if you've got an increased level of exudate, it's an indicator of infection in a biofilm. Then we move on to the wound edge. So we want to be looking for things like maceration. Is the wound looking really wet on the edges? Because that obviously can indicate, again, high exudate levels. Is there undermining? If there's undermining, obviously you're not seeing all of the wound bed because some of that wound bed goes under the undermining tissue. So you're going to have to factor that into your treatment choice as well. Dehydration is the wound bed edge dehydrated, because then the cells aren't going to move over and close that wound up. And have you got rolled edges as well? So rolled edges you probably won't see in a surgical wound as much, but it's good to be aware of them because normally they're more of a case of an underlying condition going on there. And then you've got your peri-wound skin assessment. So again, you've got maceration and excoriation, which can be, again, linked to exudate levels. As they've got dry skin, which is then, if that then flakes off or if it's dry, it can break down that protective barrier. You've got hyperkeratosis, which again, you probably wouldn't see in a surgical wound necessarily, but you might do if it's on a lower limb that's also got chronic leg ulcers, any callus or eczema as well. And all this is going to affect your treatment options for the peri-wound skin. Surgical site infections can delay healing in surgical wounds, and they're quite often referred to as an SSI. Clinical signs and symptoms usually occur within 7 days, with 50% of the SSIs becoming evident after discharge. So if you think back to what I said before about these enhanced recovery programs, they are going to be picked up in the community and primary care settings. All surgical site infections should be reported up to 30 days post-op, or 90 days if implants have been involved, and you just do that through whatever your incident reporting system is. So you want to be looking for your clinical signs and symptoms of infection. So your local infection symptoms, you want to be looking for warmth, erythema, swelling, increased or purulent exudate, delayed healing, friable granulation tissue. And then for your spreading and systemic infections, you want to be looking for your increased erythema. So as that redness really started to spread over the peri-wound skin and to the other areas as well, have they got pyrexia? Has the wound now started to develop abscess or a pus? And is the wound completely starting to break down? So surgical wound dehiscence, this refers to when there's a separation of the margins of the surgical wounds which was closed through closure materials. So like we were saying before, like your primary intention. It can be caused by a surgical site infection. However, it can also be caused by hematomas, seromas, mechanical stress, obesity, or pre-existing chronic disease states as well. So it doesn't necessarily just mean that there's a surgical site infection there. It could mean there's other things going on as well, and that's why you need that full holistic assessment. It is critical to determine the extent of dehiscence as soon as possible and whether the wound requires secondary intention to heal or surgery. So it's really, that is where your assessment and that thorough assessment really comes in to determine if you need to kind of take them back to theatre for closure, or whether or not you can then just step down to a secondary intention closure. If a surgical wound breakdown is identified and recognised as early as possible, outcomes can be improved. An accurate and thorough clinical assessment should be used as soon as possible. So the National Wound Care Strategy Programme obviously have their recommendations, and their recommendations assessing for red flags. So this is when you would seek further advice. So if you've got a wound that's got a surgical infection or a dehiscence, this is what you do. So if there's a hemorrhage or a catastrophic dehiscence, so you've got a burst abdomen with visible organs, this is an emergency. You need to ring 999, get an ambulance and get them blue lighted straight back to the acute services. If there's signs of systemic infection or sepsis, you want to be looking for an immediate review by a senior clinical decision maker, so whoever that is in your areas, and you're probably going to want to be getting them. If the signs of sepsis, you probably are going to be wanting them, getting them to A&E. You'd seek a review by a surgical team within 24 hours for a spreading cellulitis or a dehiscence if the surgery did involve implants, or aesthetically or functionally important to the surgical site. So if it's on the face, or if it was surgery over the joints or anything like that. And you'd seek a review within 72 hours by the surgical team if the dehiscence exposed subcutaneous layers or fascia. You'd also do it if there was suspected sinus, fistula or tunneling, and a stoma was in the boundaries as well. So if the stoma is within that kind of peri-wound skin area. So that was kind of assessment. So what we'll do is we'll move around now and go on to prepare. So slough, non-viable tissue and biofilms can all delay the wound healing process, as they can increase the risk of infection, they can inhibit the development of healthy tissue and limit wound assessment. And as I've already previously touched on at the start of the webinar, 80% of non-healing wounds can contain biofilms. So it's really important that we prepare our wounds to get rid of all these issues that can stop the wound from healing. It has been clinically proven that cleansing and debridement does speed up wound healing. So these are results from the Wilcox study that was done in 2013. And the results on the screen are just based on diabetic foot ulcers. However, the study did a whole range of wounds and a whole range of different patient demographics. But for the purpose of this, what you can see on the screen is that in diabetic foot ulcers, if a wound was debrided at least once every 2 weeks, it took on average about 76 days to heal. However, if you increase that debridement to once a week, the wound went on to heal in 21 days. So quite a significant difference from just adding in another debridement once a week. Holistic assessment directs wound preparation that includes washing, cleansing and debridement. So washing, you want to wash the surrounding skin, the limb, and to maintain a healthy environment and avoid any further complications. So if you think about, we've just said there, if there's a stoma within the boundaries of the surgical room, you really want to be giving that area a good clean. Cleansing will remove loose surface contaminants, debris and bacteria, excess exudate and wound dressing remnants from the wound bed as well. So them two areas that are in green on your screen don't require obviously extended competencies and training. However, when we move down onto the other areas of more debridement, you've got your autolytic debridement, which is your body's attempt to shed devitalized tissue through the use of moisture. You've got your mechanical debridement, which is the physical removal of devitalized tissue using friction. So that's your debridement pads, things like that. Then you've got your biological debridement, which is maggots, and your enzymatic debridement, which is your ointments and gel. So these do not require extended competencies. However, you may need to have some extra knowledge and skills on the products and obviously the different methods to do it to be able to perform them correctly. And then you've got your sharp debridement, your surgical debridement, which is the use of scalpels and forceps, either in a sterile setting or obviously surgical debridement is normally done in theatre. And this is where you do need your extended skills and competencies to be able to do that. So anyone can do any form of washing, cleansing and debridement if you look at the ones that are in green. And then if you do have the skills and the skills, you can move on to the ones in blue. International best practice for management of biofilms and infection do say that it's not a one-step solution. Different treatment strategies must be used. So the first step is we want to do wound preparation. So we need to cleanse and debride to reduce the number of microorganisms that are disturbing and removing some of the biofilms. So that would be your use of your all prep pad. So you want to be going in and giving your wound a really good kind of mechanical debridement using all prep pad to clear out all that devitalized tissue and anything that's inhibiting wound healing. Step 2, you'd then go on to apply a barrier dressing. So if there's sign of infection, you'd use something like biotin, silicone AG. If there isn't, you'd just go down to your biotin. And obviously step 3 is if there is infection, which I've already covered. So the wound, as I've said, if you look back at the Wilcox study, if a wound is debrided at least once a week, it does accelerate healing times. And the aim of wound preparation is to continue to do that or to facilitate the effective management and treatment plans. It is an approach that should be undertaken at each wound care intervention, but obviously you want to be doing your wound assessment using your clinical judgment, your treatment goals, and the patient's pain levels also need to be taken into consideration when doing this. But if you explain to the patient why you're doing it and what the need for wound preparation is, the patients are a lot more able to tolerate any pain that they might have to kind of get on top of everything and accelerate that wound healing, and they have less time living with a wound. There is times when we do need to be cautious with wound preparation though. So if a patient has a wound on the lower limb and is known to be a diabetic, it's probably best and more suitable to get a bit more specialist advice. If they've got a known arterial flow concern or local tissue perfusion, poor localized tissue perfusion, you probably want to again avoid wound preparation where in some areas. If the healing ability is impaired because of medications or underlying medical conditions, so if they're immunosuppressed using psychotoxic medications like chemo, and if obviously you've got exposed organs, and that is stated in the National Wound Care Strategy Programme's red flags as well. So we'll move on now to treat. So you want to be identifying your treatment objectives, and you'll start doing this in your wound assessment and as you go through onto your wound preparation. So you should aim to support optimal healing environment for that wound. So you want to be looking at your objectives. Is there exudate and is it pooling? Do you need to protect the peri-wound skin as well? If the exudate's pooling, is it going to end up with your macerated peri-wound skin? Is there any maceration or excoriation? What's the depth of the wound? Is there a cavity? Are you going to have to look at a filler, or are you going to be able to utilise 3D fit technology? And is there any infection or biofilm there? So the dressing selection that you choose plays an important role in surgical wound management and can help prevent and minimise risk. To improve the outcomes of the incision care, consideration needs to be given to the surgery type, the wound status and individual patient circumstances. So you should have flagged this up obviously as well in your wound assessment. So your different Dressing choices depending on your objective. So if you've got a dehisced wound, you want to refer back to your National Wound Care Strategy Programme red flags. If there's a large dehiscence, you want to get immediate advice from your surgical decision maker. So it could be the surgical team, it could be tissue viability, it might be somebody a bit more local to your area. If there is no emergency or immediate review flags, consider what's the wound depth. Again, is it larger than 2 centimeters? Are you going to need a filler, or can you utilize 3D fit? What's the exudate levels? Is there any tunnel or undermining, and is the patient also in pain with it? If you then have a dehisced wound and there's also signs of a surgical site infection, you still want to be looking at your red flags and moving down them. If you don't identify any of them, you also then need to factor in everything that I've just discussed, but also factor in an antimicrobial to treat the surgical site infection. And if the wound hasn't dehisced, you want to do, if it's a surgical site, you do want to be doing a microbiology swab because it helps with the surgical site infection reporting. And if a primary closure is still intact, just consider your antimicrobial dressing choices. So when would you implement an antimicrobial? And this is some things that I have actually seen in practice, and antimicrobials are often not utilised when they should be. So if your wound is contaminated or colonised, topical antimicrobial dressings are not indicated because the bioburden that's going on in the wound is not causing clinical problems. You can continue with just your standard dressings. However, if we move on and you've got signs of local infection, this is where you want to be implementing your topical antimicrobial dressing. So if you're starting to see that erythema, you're starting to see a little bit of increased exudate levels, this is where you want to be getting in there. Once you get to your spreading infection or your systemic infection, you want to be adding in your antibiotics as well as your topical antimicrobial dressing and using them in tandem. So antimicrobials are available in every different form. You name it, there is probably a product out there that's got an antimicrobial in that form. So you've got liquid paste, creams, ointments, sprays, impregnated dressings. Depending on the product, depends on how you can use it. So some can be used every day, but only for a short period of time. Others require reapplication several times a day. Some can only be in contact with the wound for a few days at a time. There is one out there as well that can only be in contact with the wound for 20 minutes and then it's got to come off and you can't use it again for 72 hours. So it's really important that you know inside out the type of dressings that you're using and how they're intended to be used. Your main types of antimicrobials that you're going to see are your honeys, your PHMB, your iodine and your silver. Silver has been used for thousands of years in wound care to prevent and treat infections. It's been available in solid elemental form, in salts to help clean the wound, in creams and ointments that contain a silver antibiotic compound. In recent years, a wide range of wound dressings containing silver have been developed, and they're obviously easier to apply and they can provide a sustained release of silver. So that means less frequent dressing changes as well. But it also means that biofilms can grow back within about 24 hours. So if you've got a silver dressing on an infected wound that's got a sustained release, it's preventing that biofilm from also growing back. Silver has a broad spectrum antimicrobial effect against bacteria, and that's both gram-negative and gram-positive. Silver has shown to prevent biofilm formation in vitro studies. Silver targets multiple sites of bacteria, so silver ions bind to the bacteria cell wall, blocking the transport of substances in and out of the cell, so it stops it kind of working as well as what it probably should be. The silver ions are also transported into the bacterial cell where they can block the respiratory system and destroy the energy production, so it stops the cell from breathing, basically. And then in the bacterial silver cell ions interact with the DNA and inhibit this bacterial cell from division, so to stop it replicating. So they basically go in there and just destroy it from the inside out. So as we said, we've got the international best practice for the management of biofilms and infection. So we talked about step 1 being wound preparation. So that is obviously the use of all prep pad and mechanical debridement. And then you've got step 2, which is applying your barrier dressing, which will prevent maceration, will help the management of exudate and prevent recontamination. And then you've got your infection management, which suppress your biofilm formation, which is what I've just discussed with that sustained release. So for antimicrobial usage, we recommend the 2-week challenge. So duration of antimicrobial use should be on an individual assessment and should be done as part of the regular wound assessment, but it is recommended to use the 2-week challenge to determine the clinical effect of silver and its had. After this period, the wound to the patient and the management approach should be re-evaluated according to the figure on the screen. So if you've been using your biotin silicon AG for 2 weeks and you come to your reassessment and there's no improvement, the silver dressing should be discontinued and you need to give consideration to a different antimicrobial agent, or you really need to be then looking at, a systemic antibiotic. Has the infection got any worse? If after 2 weeks you've got improvement and there's no signs of infection, your silver treatments work and be discontinued and you can step down to something like a biotin silicon. If after 2 weeks you've got improvement but there's continuing signs of infection, treatment with the silver can be continued just with regular reviews until you kind of get to that middle step where it's improved and you've got no signs of infection. So at Coloplast, we're here about making life easier, and that's why we've obviously developed the 3-step approach to help simplify in wound healing and make it easier. So it's 3 steps that you need to remember: assess, prepare and treat. This is just a case study. So this is a 55-year-old male who had a big toe amputation due to type 2 diabetes following arterial insufficiency. As you can see on that first picture, you've got a bit of maceration there to the wound edge. The wound bed looks, from that photo, looks very friable, which would indicate there's probably an infection there. So step 1, you want to be looking at your assess. You want to be creating that optimal healing environment. You want to be removing the non-viable tissue, which you can kind of see there. There's a bit in the middle on the wound bed, and there's some towards the wound edge as well. You want to be managing the exudate levels. Like I said, that wound edge is macerated, so it indicates that there is a higher level of exudate that we'd like. You want to be looking at the bacteria, managing the bacterial burden, protecting the granulation and epithelial tissue, and just protecting the peri-wound skin as well. So step 2, you want to be preparing using all prep pad that would lift all that devitalized tissue off and help disrupt any biofilm. And step 3, you'd be utilizing your biotin silicon AG to help with that bio burden. And as you can see, there's some amazing results from week 1 to week 9, and then week 14 it's almost closed. So the results from this case study: the wound decreased from 18 centimeters by 7 centimeters to 4 by 1 centimeters in 14 weeks. So quite a significant difference. As you can see from the photo, day 1 to day 14, the actual top of the wound is closed and it is now healed, and it's just the bit kind of more central to the foot that's still got a little bit way to go. The exudate levels to the remaining wound, so the week 14, are low, and there is no signs of local infection, and the patient's wound score is only 2. The wound no longer requires an antimicrobial to manage the bacterial burden. It's currently being treated with biotin silicon. So massive improvements from day 1 to week 14. So this is the pathway that I said that we're just going to we're reviewing in-house at the moment. So if you do come across a non-healing surgical wound, you'd use a triangle of wound assessment and the assess, prepare, treat. Complete a holistic assessment, look for the red flags. If there is any red flags, you'd follow them accordingly. If not, you'd then step down and you'd treat the wound depending on your objectives that you identified at the assessment stage, and then you would reassess. Like I said, the National Wound Care Strategy updated their recommendations earlier on this month, so we're just in the process of reviewing this pathway in-house so that we can get the right information cascaded. And then depending on obviously what you've done in your assess and you prepare, your treat would then depend on whether or not there's an infection present, or if there is an infection present. So if you've got no infection present, but you've got between 0 and 2 centimeters of depth, you can utilize biotin silicon. If there's greater than 2 centimeters of depth and or there's tunneling or undermining, you can use your biotin fiber with your biotin silicon. If you do have infection present, If the wound is below 2 centimeters, you can use biotin silicone AG. If it's over 2 centimeters, you want to be looking at your biotin alginate AG or your biotin silicone. And if you want any additional support from us on our products, our services, there's a scan a QR code that's there, and we can get you some more information, and someone from our team can give you a call to discuss either face-to-face or virtually. We also have some podcasts that are available, so you can listen to my colleague Charlie, who's manning the chat and is on the call with me today, and our other colleague Sam, while they talk about all things wounds, and you can find them on iTunes, Apple, Spotify, anywhere where you get your normal podcasts. And that's everything from me. Thank you very much.